Hello everyone, and welcome to this NANSIG tutorial on head injury. My name is Richard Bartlett, and I'm one of the medical students at UCL. And the content for this tutorial has been very kindly developed in conjunction with Mr. Aswin Chiari, who's one of the neurosurgical registrars and academic clinical fellows on the North Thames rotation. Over the course of the next 30 minutes or so, we aim to go through all the key aspects of head injury. However, in particular, we'll focus our attention on the neurosurgical management of the condition. The level of information provided in this tutorial is aimed to be applicable for students in their final year, yet we hope that this resource will serve as a useful teaching aid to medical students at any stage in their training. So, first of all, a little bit of background about head injury. Really, head injury is a catch-all term, and it can be used to describe any trauma to the scalp, skull or brain. Overall, it's the most common cause of death in the under 25s, and it typically has a high predilection to affect males. So if you look in the textbooks, you'll classically see this 3-to-1 male to female ratio banded around. Now, the reasons for this kind of skew in who it affects are not fully understood, but it probably centres around the fact that most head injuries are a result of high energy impacts. And we can divide these into either blunt trauma or penetrating trauma. So in terms of blunt trauma, we have things such as falls, road traffic incidents, which you can see on the top right, sporting injuries or assault. And in terms of penetrating trauma, we have things such as bullet wounds, knife or stab injuries, or actually any other object which passes through the skull. And as you can probably imagine, the cost of head injury to society is substantial. So in terms of direct costs to the NHS, it's estimated to be around £1.5 billion per year, but actually the indirect costs of head injury are probably much greater than this. And this is because it primarily affects a young working demographic. And this means that obviously people can't go to work and there's a loss of economic productivity. Now, one other thing which is really important to be aware of in the context of head injury is the psychiatric morbidity associated with it. Now, I won't go into too many details about this because it's quite a complicated area. But if you do want kind of more information about this topic in particular, then there's a good paper referenced at the end of this tutorial by McAllister et al. In 2008. But just to give you the headlines and a kind of summary of what you kind of might expect to see in patients, what relatives will often describe is that after a head injury, their loved ones will become different in terms of their kind of neurological behaviour. And the changes we see are typically associated with changes to frontal lobe function. So the things we might expect to see are a loss of executive function, deficits in problem solving, problems with memory or learning, and also difficulties in speech or language. However, just as commonly, relatives may also say that their loved ones have become more impulsive, they may say they've become more irritable, and it has been noted that they can also become more emotionally unstable. And so perhaps a useful aid memoir to kind of remember these kind of themes, if you like, if asked about it in an exam, is the 3 I's of head injury. So impulsivity, irritability, and instability. So we've had a look at the background of head injury, but now let's turn our attention to the underlying pathophysiology. First of all, it's safe to say that head injury has a complex pathophysiology, and this is not fully understood. However, a useful way to structure our thoughts may be to think about the microscopic, macroscopic, and resulting functional deficits which occur. And as we saw on the previous slide, head injuries typically result from high energy impacts, and these cause rapid acceleration or deacceleration movements of the head. And if we take the example of a traumatic blow to the head, as we can see in the centre image of a baseball bat, then we see that an initial coup injury occurs at the site of impact. This is ipsilateral to the direction of the initial blow and happens as a result of the cranial vault being rapidly pushed backwards onto the brain. In this example, there is also damage to the anterior aspect of the brain. However, moments later, after this initial coup injury has occurred, a subsequent contra-coup injury ensues. This is where, due to the density differences between CSF and the brain is left behind as the skull accelerates, and this subsequently pushes it backwards in the skull. And as it moves backwards, it eventually hits the occipital bone and can cause damage to the posterior aspect of the brain. So this is what we call a secondary impact. In addition to these areas of direct impact, though, there can also be indirect damage. This occurs mainly as part of a phenomenon called diffuse axonal injury. And this describes how the high shear forces which are generated during the rapid acceleration and deacceleration movements of the head cause damage to the myelinated white matter. At the cellular level, this disrupts axonal transport, and eventually it leads to microglial activation and scarring. But diffuse axonal injury may also manifest itself macroscopically as disconnected white matter tracts, and functionally this localizes to kind of commissures and other areas of high white matter density. And obviously, when damage to these tracts occurs, it disrupts network function, and this manifests as the neurobehavioral changes which we discussed on the previous slide. And so in summary, we can collectively refer to these types of injury which occur after high energy impacts as traumatic brain injury, which we'll call from now on TBI. And this is what we'll focus on for the remainder of this tutorial. When discussing traumatic brain injury, there are two types of injury which we need to consider. These are primary injuries and secondary injuries. Primary injuries occur as a direct result of the injury itself, and they can be either focal or diffuse. Focal injuries include things such as contusions, hematomas, and infarction. Diffuse injuries can be classified as either diffuse axonal injury, as we've discussed, hypoxic brain injury, edema, or global vascular insult. But because all of these primary injuries occur at the time of or directly as a result of the injury, they are irreversible and unpreventable. And as such, there's no scope for medical or surgical intervention here. In contrast, secondary injuries occur after the initial injury. They may be caused by things such as raised intracranial pressure, or raised ICP, hypoxia, hyperperfusion, or infection. And so, in contrast to the primary injuries, all of these secondary injuries are modifiable and preventable. As such, they're the mainstay of targets for medical and surgical therapies. It is the reduction of secondary injuries which we'll focus on in our workup and management of our TBI patients. So we've discussed the background and pathology of head injury, but what do we actually need to do when a patient comes through the doors of A&E? Well, as with most things in medicine, it's best to take a structured approach. So although the patient may have an immediately obvious head injury, it's important not to overlook, or worse still, actually miss other life-threatening injuries. After all, many of the patients who are admitted with severe head injuries will be polytrauma patients, and as such they may have multiple, and actually sometimes quite extensive injuries elsewhere which need to be managed first. Now, of course, it's highly unlikely that you'd ever be expected to deal with the situation on your own as a junior doctor, but it's still important to have a basic idea of the initial management. So similar to any other acutely unstable patient, it's important to adopt the ABCDE approach in accordance with the ATLS protocol. This involves first stabilising the airway of the patient before then moving on to manage and assess other key systems such as breathing, circulation and disability. Now there isn't time to go through all the details of the ATLS protocol here, but for those who are interested there is a link provided at the end of this tutorial. However, perhaps one of the key things to remember from ATLS is that we must ensure that the patient is stable before moving on to the next part of the algorithm. So this involves a continual cycle of reassessment and immediate management. But in the case of head trauma specifically, there are a few things to point out from the ATLS protocol. Firstly, the C-spine should be assumed to be damaged until proven otherwise, and as such all patients should be put in a collar and stabilised. And equally, it's really important that we build up a neurological baseline of how our patient presents. And so things such as GCS, gross focal neurology, and pupil reactivity should be documented and done both at the time of injury, during transit, and at the point of admission. And this allows for a deteriorating patient to be picked up early, and consequently their management to be escalated appropriately. And in severe head injury, it's also really important to actively look for signs of CSF leakage, because these may suggest things such as a basal skull fracture. So it's really important to look for things such as rhinorrhea, otorrhea, battle sign, and the kind of classic raccoon eyes. And obviously after all of this is done, it's important that we complete a secondary survey to look for any other kind of injuries around the body, and also to take any relevant investigations immediately, such as bloods. When it comes to classifying head injury, the Glasgow Coma Scale, or GCS, is perhaps the most useful prognostic indicator. This is a scoring system which I'm sure most of you are probably already familiar with, but for those who aren't, it can be seen depicted on the left. Broadly speaking, it's divided into three areas, which assess eye-opening, verbal response, and best motor response. The subclassifications of each of these areas can be seen, and each of them has a slightly different weighting. These then contribute together to form an overall GCS score, the maximum of which is 15. And so a score of 15 indicates that there's no pathology, whilst at the other end of the spectrum, a score of 3 would indicate that a patient is totally unresponsive. And this is an important distinction to make, actually, because on this particular scale, a score of 0 isn't possible, even if the patient's dead. So the lowest score achievable is 3. Another important cut-off score to be aware of is 8, and this is because it's at this point which patients are no longer able to maintain their own airway, and at this point they'll require intubation. So that's an overview of the Glasgow Coma Scale. And we can use the Glasgow Coma Scale to stratify and classify head injury. So in the case of traumatic brain injury specifically, there are 4 categories which we can use. So these are minimal injuries, or concussive injuries as they're sometimes called, mild injuries, moderate injuries, and severe injuries. So in minimal injuries, patients will be fully alert, have a GCS of 15. So they're patients who've just had an injury, but there's actually no kind of clinical evidence of an injury. Patients with mild injury will have a slightly decreased GCS between 13 and 15. But again, this is not really associated with an increased mortality. But as soon as we start getting to GCS levels lower than kind of 13, so in moderate injury and severe injury, the mortality begins to increase sharply. And this is an important distinction to make because the relationship between the GCS score and overall mortality is not linear. So as the GCS score decreases, the mortality rapidly increases. So as a junior doctor on the wards, if you see somebody with even a slightly decreased GCS, then you need to be really quite worried about them because they have a much higher chance of dying. One of the most important investigations to consider in head injury patients is that of a CT head scan. And here on the slide we can see the NICE guidelines for CT and head injury. It should be noted, however, that these are the adult guidelines and those for children will differ. And similarly, although these guidelines are relevant to head injury, many of the patients, as we discussed, will be polytrauma patients, and these will bypass these specific head injury guidelines and will automatically qualify for a full CT head abdo-pelvis, regardless of other clinical features. In terms of head injury only patients, though, there are 2 stratifications for when a CT should be performed. The first is within a 1-hour window, and the second is within an 8-hour window. Now, the specific criteria for when each of these should be performed largely follow common sense. So, if there's any major impairment in GCS, then patients will automatically qualify for a 1-hour CT head. Likewise, if there's any signs of bony trauma, such as an open or depressed skull fracture, this will also automatically warrant an immediate scan. Similarly, if there's any signs of basal skull fracture or functional problems, such as post-traumatic seizures, focal neurology, or repeated vomiting, then this will also immediately warrant a CT head. In contrast, the criteria for the 8-hour CT window primarily focus around safeguarding high-risk patients. So these are patients who might not have had a particularly severe injury, but are at higher risk once they're discharged from hospital. So namely, these include groups such as those who are over 65 years of age, patients with any known clotting disorders, or patients who take anticoagulants such as warfarin, for instance, or also if there's any persistent functional loss, such as a retrograde amnesia lasting greater than 30 minutes. And finally, there's also a slightly discretionary and catch-all term, which you can see on the slide, called suspected dangerous mechanism of injury. And this will arguably include most people who've had a head injury, so people such as car crash victims and things like that. And this term really gives clinicians quite great flexibility in sending for a CT and justifying it. So that's the overall criteria for CT heads in head injury. But as a final kind of minor point, it's important to be aware that CT will not actually detect diffuse axonal injury. And therefore, although CT is a useful first-line investigation and a useful initial imaging investigation, it probably needs to be followed up by an MRI if diffuse axonal injury is suspected. And we can't actually exclude diffuse axonal injury on the basis of a CT alone. So our patient is stable and they've had their initial imaging, but where do we send them? Again, there are nice guidelines to direct the appropriate admission and referral of head injury patients. And like on the previous slide, these are the adult guidelines. So the criteria for admission to hospital largely follow common sense again. If there are any new or clinically worrying abnormalities, then patients will obviously require admission. Other reasons to admit include a GCS of less than 15 after imaging has been performed, continuing worrying signs such as persistent vomiting or headaches, or any other kind of general clinician concerns. These may include situations where the patient is believed to be incapable of looking after themselves, such as in drug or alcohol intoxication, or where suspected non-accidental injury may have occurred. Equally, if there are other concerning comorbidities such as meningism or CSF leakage, then this will also qualify the patient for automatic hospital admission. We also have to consider whether we need to refer to a neurosurgical team. This may occur either prior to the initial hospital admission, such as in cases where there's penetrating injury or suspected basal skull fractures, or where there's ongoing deterioration. For example, if there's a progressive neurology or a seizure without recovery, then it's likely that neurosurgical intervention will be required at some point. Other criteria for immediate neurosurgical referral include a GCS of less than 8 after initial resuscitation, unexplained confusion at 4 hours post-injury, or deterioration after admission. Now, these guidelines can seem quite complicated, but really if you follow kind of a common sense approach based on how acutely unwell the patient is in front of you, then you're unlikely to go too far wrong. However, if in doubt, it's obviously always best to check the guidelines. So as we mentioned earlier, when we're managing traumatic brain injury, one of the major modifiable forms of secondary injury which we can treat is raised intracranial pressure, or ICP. And managing the ICP is probably a concept which many of you might be familiar with, given that it's often a favourite quiz question in theatre. Nevertheless, it's a really important concept to be aware of and understand. In essence, what we can do is think of the skull like a closed box. Its volume is fixed, and whatever goes in must come out. This is what surgeons will often refer to as the Monro-Kelly doctrine, or the closed box analogy. And this fixed compartment, the skull, has 3 major components which fill it. These are the brain, the blood, and the cerebral spinal fluid. And thus, given that the skull is always full, if the volume of one of these 3 compartments increases, then the volume of one of the other 2 must subsequently decrease. In physiological circumstances, this regulatory system works really well. For instance, if you go out for a run and your blood pressure increases, then the volume of your cerebral spinal fluid will transiently decrease to maintain a stable ICP. And this phenomenon is known as autoregulation. And in healthy individuals, the ICP is very tightly maintained between approximately 5 and 10 millimeters of mercury. If, however, the brain undergoes profuse edema, such is the case in traumatic brain injury, then the system runs out of buffer room, and this results in dysregulation. In this situation, the system is no longer able to compensate, and the ICP begins to rise. And as we can see from the graph on the bottom left, once it does begin to rise and this point of decompensation is reached, it rises very rapidly. And as it increases, we'll see decreases in neurological function as the brain is compressed. And if it gets to a point which is really high, around 60 millimeters of mercury, the brain will actually herniate. Now, we can attenuate this rise to some degree using medical therapies though. For instance, you may recall from your preclinical years that cerebral perfusion pressure is equal to the mean arterial pressure minus the ICP. And although we can't alter the ICP directly, we can alter the other 2 components of this equation, so the cerebral perfusion pressure and the mean arterial pressure. And we do this using autonomic drugs. And these are the drugs which we typically use to control blood pressure, for instance. And what we want to do when we're managing the ICP is try and maintain the parameters in the bottom right to maintain a stable ICP. And I should just say at this point, although this model works, and this is what is currently used to base treatment strategies on in clinical practice, there has been a very recent paper published in 2016 which indicates that actually the mechanisms underlying this might be a little bit more complicated than this. So if you're interested to know more about the kind of really fascinating physiology which underlies this relationship, then I'd recommend you check out a paper by Wilson et al. In 2016, which is referenced at the end. So we now know about the different components which regulate ICP, and we also know why controlling ICP is important in the context of minimising secondary insult and head injury. So let's now turn our attention and apply what we've learned to current clinical practice. Broadly speaking, ICP lowering techniques can be divided into either medical or surgical interventions. And as one would expect, medical intervention should be favoured first line over their more invasive surgical counterparts. In terms of medical interventions, one of the most important and immediate things to do in a patient with raised ICP is to elevate the head. The textbook description of this is to raise the head to approximately 30 degrees. Now, it's important to note that this should be done through tilting the bed and maintaining a neutral neck position, not through kinking the neck. The reason for this is that through kinking the neck we obstruct venous outflow, and thus we will subsequently increase ICP further. For the same reason, any tight collars or clothing around the neck must also be removed. Another effective yet simple intervention is that of forced hyperventilation. This induces a hypocapnia and reduces the circulating concentration of CO2 in the blood. Now, as you may remember from your basic physiology, lower levels of CO2 in the blood promote vasoconstriction in the brain. As such, we reduce cerebral blood flow and thus lower the overall volume of blood in the cranium. And we now know from the Monroe-Kelly doctrine that blood is one of the three major components which contribute to ICP. And so if we reduce the circulating volume of blood, we'll reduce the ICP. And clinically, it's important to note that we aim for low to normal PaCO2 values in head injury patients. Mannitol is also a medical intervention which is regularly used in ICP control. Mannitol is a potent osmotic diuretic and thus reduces cerebral edema by removing water. It's important to remember, however, that dose must be titrated in accordance with body weight, and the drug can only be given by slow intravenous infusion. And finally, although hypothermia has been speculated to be of use, as I'll show you in a later slide, the evidence for this is weak. As such, it's currently recommended that hypothermia is avoided in head injury patients. Now, in those patients where medical management fails to sufficiently lower ICP, surgery must be considered. Now, a recent trial has shown that aggressive ICP monitoring gives better outcomes, and so ICP bulk should have a low threshold for consideration. Where ICP is uncontrolled despite the best medical management, though, other surgical interventions are available. We'll discuss these in more detail on the next slide, but they include extraventricular drains and decompressive craniectomy. Similarly, however, if the primary cause of raised ICP is bleeding, for instance, an extrajaw hematoma, then this will need to be surgically excised if we're to regain control of the ICP. So now, let's take a closer look at the surgical techniques which can be used to reduce ICP. So, just before we finish, there are a few key clinical trials to be aware of. These almost certainly won't be tested in medical school exams, but they do help paint a useful picture of where the neurosurgical management of ICP has come from, and also where it's likely to be going. The first of these is the so-called DECRA trial. This was a multi-centre trial conducted in Australia, and aimed to investigate whether decompressive craniectomy was useful in reducing raised ICP following traumatic brain injury. The trial concluded that bifrontal craniectomy was successful in reducing raised ICP, and also that it reduced the need for medical management such as mannitol, mechanical ventilation, and length of stay in ICU. Nevertheless, the bifrontal craniectomy group saw an increased rate of complications such as hematoma and hydrocephalus, and functional assessment at 6 months was actually worse than that of the control group. These results cast decompressive craniectomy in a negative light, and understandably many experienced surgeons had reservations about the applicability of the study results to the general TBI population. Many felt that the ICP threshold for recruitment was too low, and that bifrontal craniectomy was an excessive operation for many patients. As such, a UK group has recently published the results of Rescue ICP, or the randomised evaluation of surgery with craniectomy for uncontrollable elevation of intracranial pressure. Rescue ICP aimed to address some of the limitations of the DECRA study, and consequently patients were only recruited into the trial if their ICP was greater than 25mm of mercury despite optimal medical management. Moreover, the trial design was generally more pragmatic than DECRA, and it gave surgeons the option of performing either a bifrontal craniectomy or a unilateral craniectomy, providing they recruited into the treatment arm. Overall, Rescue ICP concluded that decompressive craniectomy resulted in better survival rates, but generally patients who underwent surgical intervention had a higher level of disability at 6 and 12 months. Patients in the decompressive craniectomy group also spent less time with an ICP greater than 25mm of mercury, but they had higher rates of adverse complications. And so those are the two main clinical trials to be aware of. However, other trials include the Chestnut trial and the Eurotherm trial. In short, the Chestnut trial established that patients with intracranial pressure monitoring do better than those without. Eurotherm showed that although hypothermia can successfully reduce ICP in the acute phase after TBI, at 6 months functional recovery was actually worse in hypothermic patients than in normothermic patients. And so if you're interested to read more about these seminal trials, there are links to the full papers at the end of this tutorial. So in summary, this is a flowchart taken from the Rescue ICP study protocol, and it serves to illustrate two things. Firstly, it should serve as a useful summary of what we've covered today, and secondly, it serves to illustrate where we are right now today in terms of our evidence base. So we know that we should be managing patients with basic measures such as head elevation and hyperventilation. We also know that monitoring their ICP is extremely important in reducing secondary injury. And where ICP remains uncontrolled despite these basic interventions, we know that we then need to move on to more invasive kind of management such as inotropes and the use of mannitol. But what we still really don't know is in those patients where ICP remains persistently raised for a prolonged period of time, we still don't know whether we should be ultimately managing those patients with surgery or with medical interventions. So that's where we are today. Hopefully we'll have the answers of what to do soon. And so thank you for listening. We hope you found this tutorial useful. Please do check out the additional reading at the end. We split this into core reading, which is likely to be useful for anyone about to sit exams, and also additional reading for those who are just generally interested in what we've covered today. With your newly acquired knowledge, we'd also recommend that you consolidate it by having a go at some of the SBAs we've compiled. So good luck with your exams, and thank you for listening.